Dear jury, sehr geehrter Herr Kandov, I'm really happy to be here again, another progress report, and I will talk about my PhD studies, which is investigating the total knee arthroplasties. I am Bence Stubnya, working at the Department of Orthopedics at the Semmelweis University, and as a student researcher, I felt really special, exciting feelings when I saw the first total knee arthroplasty and the patient day after trying to walk. So I was asked for a student research work, what I converted to my PhD studies. The thing behind my interest is the extreme growing regarding the total joint arthroplasties. As I read in Germany, in the German registry, there was 20,000 total knee arthroplasties in 2024, but it grew to 100,000 in just 7 or 8 years, which means 5x increasing. And in Hungary, this number is a 300% just in 10 years. But reading the international literature, there is still no consensus about the most and more effective surgical approach. So my specific goals and project plans were about to investigate the surgical approaches regarding total knee arthroplasty via literature research, via a clinical trial, and a registry analysis. So my first topic was a systematic international literature review, where we tried to investigate the subvastus approach, comparing all the other used approaches all around the world. Here you can see my selection process, my search key, the data search and databases. At the end, we found only 33 randomized control trials, which was good enough to include to our systematic analysis. The first outcome we investigated was the range of motion. Here is a big forest plot where I show you the first postoperative weeks, and the reason why we choose to investigate the postoperative days and weeks, because I've read a lot of articles about the half-year and 1 year follow-up, which were comparing the different surgical approaches, but there was no meta-analysis regarding the first days and first weeks after the surgery. And we were trying to investigate and find a way to the possibly reachable fastest recovery and supporting the fast-track total knee arthroplasties. So what we found is on the figure, we compared all the approaches to the standard used medial parapatellar approach, and on the right side of the plot, you can see if an approach is better than the medial parapatellar approach regarding the range of motion. Here you can see the cross-sectional data, like the days, the number of included articles, and the sample size, the cross-section yes, the sample size, yeah. And at the end of the figure is a rank plot. And what we found was that there is a significant difference between the subvastus and the medial parapatellar approach on day 1, 3, 4, and 6 regarding the range of motion, and there was no other approaches which could show such a big difference. The second outcome we analyzed was the pain measured by the visual analog scale, and we can say that our results are very similar to the range of motion. The plot is a little bit different because the better results, which means the lower pain values, are on the left side of the figure. We compared all the approaches to the medial parapatellar approach, and there you can see that we found some significant differences between the different approaches. And regarding the pain, we found that on day 1, 3, 7, and on day 30, the mini subvastus approach was better than the medial parapatellar approach. Yes, all the studies have some strengths and limitations. We followed a very well-structured, rigorous protocol and methodology, but there is some limitations of our study. The number of articles, the cases, and the comparisons that we could enroll. The time of measurements was very heterogeneous, so we included 33 articles, but as you see on different cross-sectional lines, we cannot include the whole data set. We excluded. And most of the papers compared the subvastus to the medial parapatellar approach, and what we see is really hard to conduct a randomized control trial regarding total knee arthroplasty for different reasons. But as a conclusion, we can say that our results shows that the subvastus approach really could give a better rehabilitation for the patient, especially for the early days and weeks after the surgery. But as time goes, and half and 1 year after the surgery, those differences disappears, and there is no difference after half and 1 year. And we already, our article already is in press in the Journal of Arthroplasty. Yeah. So my second is a pilot clinical trial, because at the end we would like to make a randomized controlled trial comparing different surgical approaches in total knee arthroplasty. And here I would like to invite my colleagues from the Uzsoki Hospital to join our randomized control trial. What we included 100 patients divided into 2 groups. One group was the subvastus and the other was the medial parapatellar group with 50-50 patients. The patient groups were homogeneous. And what we found at our department is the subvastus approach really could offer better range of motion in the early postoperative days with some significant differences. And what we measured was the pain by visual scale as well, and we also found significant differences for the subvastus approach. This manuscript is under submission, and we are hoping that it will be accepted in the end of this summer. The other project which we started is worldwide registry analysis. We extracted all the data was available in different total joint replacement registries, and I will show you what the Hungarian data says. Is that from 2010 to the last COVID-free year to 2019, the numbers of total knee arthroplasties were growing with 300%. And what we are planning is a multicenter randomized controlled trial to compare all the different surgical approaches I mentioned before, and what we investigated in our meta analysis. So I'm really happy to be here, and thank you for your attention.
Thank you very much. I mean, you really do what we actually hope to see in many projects that you do a meta-analysis, then clinical registry and clinical trials. So this is great.
I try to study from the best.
Can we go to your first forest plots?
I compared several different approaches.
Anyway, so to my best understanding, I mean, actually, the difference disappears in terms of the range of motion, but the difference does not disappear in pain. So is this the pain scale? Is this really significant?
No,
because you already showed, I mean, you showed that even in 30 days there are differences too. I mean, so there are pros and cons, of course.
The differences disappears in all the outcomes after some months, half a year, and a year. So the question of our study really the early postoperative period, because we would like to support the fast track surgery. There is a really increasing numbers who are in need of total joint arthroplasty, and those people are young enough to live a whole life, and we really would like to give back their normal activities as soon as possible. So we don't, I'm sorry to say, but we don't really care about what happens after 1 year, because the orthopedics is nowadays at that point that all the arthroplasties are at the same good level after 1 year of the surgery.
I have two questions. One of them is that your measurements were really connected to the very early phase of the postoperative period, but it is also influenced by many other circumstances. For example, pain killing. In these articles, the pain killing was standardized or not. So it was always intratracheal anesthesia or LIA, for example, was used for the patient, which influenced the postoperative period in a great. The second question is that, of course, it's very important to have a very good early postoperative period for the patient. You can admit the patient if he has no pain, for example. But we are working for 20 years, 25 years. And it would be very interesting for me, for example, that the positioning of the different components are optimal in comparable in the two operations, or is there are the same or not?
Yes, thank you, Professor Sedri, for the questions. My answer for the question number one is one of the limitations of our study is that the different included randomized controlled trials does not mention the perioperative anesthesia and the pre- and post-surgical rehabilitation routines. So it is a little biased, but there is no randomized controlled trials where it is well discussed and well written down what kind of pre- and post-operative pain-killing methods were used, what kind of anesthesia were used, and so on. And the second question, this is another limitation of our study, that the randomized controlled trials didn't mention any malalignment, but in our planned randomized controlled trial, we would like to investigate the malalignment, the surgical approaches, the tourniquet usage, and the drain usage as well.
I have done quite a few total knees in my life, having been using different approaches as well. So within the last 10 years, my tactics is the next. When I approach, the knee skin incision, and if the vastus medialis is too below, too deep, then I go for mini medial parapatellar rather than midvastus, not subvastus, midvastus. So is my tactic is okay concerning your literary research and your meta-analysis?
Well, thank you for the question. I'm pretty sure it's a trap, but your methods absolutely.
I have already marked 5.
Followed by all the colleagues here. Yes.
So tell me the truth. I've already given you a 5, mark 5. Tell me the truth. Tell me your opinion, please.
What I can see after my little experience and after my
concerning your literary research
and my literature results, that always should do the surgical methods in which the surgeon has the highest experience. But if we saw a patient who is at the age around 60, has a normal BMI, has a normal active life, I would say, regarding our results, that mini subvastus or subvastus could offer the best postoperative rehabilitation results. But I closed my publication with the following ideas, that always the best approach is what the surgeons choose at the end, because the intraoperative pictures, the intraoperative situation could differ from the preoperative planning sometimes.
I remember to your talk 2 years ago was a similar stuff, approaches on the knee, and that was the question from me at that time, that when we are speaking about approach on the hip, nowadays very popular is you mustn't touch the muscle, you have to go between the muscles. But concerning the midvastus, not the subvastus, the midvastus, you go through the muscle. And if you do a mini medial parapatellar, you don't even touch a single fiber of a muscle. So according to me, for knee, it's better to have a mini medial parapatellar against the midvastus. So in my mind, but I wanted to know, according to your search, whether am I right or not.
Yes, you are right, and I would be really happy if I could have an opportunity to see one of your total arthroplasties in real life.
Not anymore. I'm retired.
I have 2 questions maybe which are more or less in this field. So let me ask you, how long is the length of stay now in Hungary after a total knee arthroplasty?
Yeah, the reason...
Because it affects this.
Yeah, thank you. The reason why I did not investigate the length of stay in our meta-analysis is because it's really different, and the factors are not the patient's results or the postoperative care. Because in a private care, they are spending 2 or 3 days in Hungary. But in the state hospitals, we have the opportunity to have our patients for an active postoperative rehabilitation for 4, 5, 6, 7 days, because we have beds and places and physiotherapists who can give our patients a better rehabilitation than we sometimes give the opportunity to our patients. But in our trial, we ask for our patients to stay 6 days at our department.
Okay, thank you. Then second of all, maybe a comment. I say that the approach that you mentioned, the approaches you mentioned are very nicely done in a normal medial arthritic knee. I would say the outliers that we might see, especially with the subvastus, is probably the severe valgus knees, because those are usually much harder to approach if you limit your incision to the subvastus approach. Does the literature did say anything about the severity of the malalignment, as you said, or nothing at all? They just mentioned OA and then did a knee replacement.
Yes, that's the reason why I mentioned as a limitation of our study that the randomized trials which were investigating the topic did not mention the malalignments. And that's the reason why I would like to investigate the malalignments in our planned study.
Thank you, but congratulations on your paper on Journal of Arthroplasty. It's not so easy to get in there.
Thank you very much.
As I know from my own experience.
This was a very interesting and really great presentation. Thank you very much. I would like to ask that regarding the first project, these approaches were for primary arthroplasties, right? My question is that in case of a revision or in case of a septic operation, what the literature suggests to use the medially parapatellar or the subvastus the subvastus or the other approaches in case of secondary so the revisions or the septic times.
Thank you for your question. Your question wasn't our focus regarding our analysis or our study, but the revisional and the revisional surgery are more complex to suggest a best protocol based on my experience and my knowledge, which I collected from the literature.
Could you go back, please, for the first project, to your project? Yes, this. On what scale were your outcomes measured?
Well, the range of motion were measured in degrees. It's a range of motion from 0 to 140, 150 in degrees.
And the second outcome?
Second visual scale is a scale from 0 to 10.
0 to 10. So not 200s?
No, it's 0 to 10.
Okay. Go back, please. Yeah. I don't understand. It can be that it is my limitation that I don't understand.
No, it's absolutely not your limitation. Probably my bad.
Med parapath.
Yes?
Always is null.
Yes, because we compared all the approaches to the medial parapatellar, which is a standard used approach, we could say. There is a study from Berstock et al. From 2008, which was a meta-analysis in the topic, investigating the usage of the different surgical approaches. And they found that most of the surgeons, which were at that time more than 90%, used the medial parapatellar approach. So that was the reason why we chose the medial parapatellar approach as a standard, as a 0.
Oh, yes, I understand. That was a network meta-analysis?
Yes, it was.
Oh, that wasn't mentioned.
Really sorry about that.